Oh, is it on? Okay. Okay. Okay, why don't we go ahead and get started? I can barely see people up there. There are seats down here if you want to be closer, but that's okay. Anyways, I want to welcome everyone to summer session. As you know, we don't have the research conference all summer, just intermittently when there's a reason to have it. And there is a reason to have it this time because we have a special guest from University of Victoria who is a world-known expert in patient safety and health IT, which is a big issue. And she's going to be spending some additional time here over the next few months, I believe. Okay. So Elizabeth Borycki is an associate professor in the School of Health Information Science at the University of Victoria. Our colleagues just up the road a bit. It's actually a shame that we don't, well, maybe this will facilitate more interaction. There's actually discussion of forming an AMIA chapter in the Pacific Northwest, kind of like they've done in the Mid-Atlantic region. So between Victoria and Seattle and here. Anyways, she brings a background in both nursing and health policy. She has her PhD from the University of Toronto, and she is going to be talking to us today on HIT safety. So,
thank you.
Yes. And
Hi, everyone. Can you hear me okay? Yes? I apologize. I'm a bit rusty on lecturing, so it always takes me a little while to get loud enough. So let me know if I'm not loud for people at the back. So today what I'm going to talk about is health information technology safety issues and solutions. So I'm going to talk a little bit about some of the research that has been going on at the University of Victoria, some of the research that I've either led or been involved with, as well as sort of mix it in with some of the things that are going on actually here. That's one of the reasons why I've come here is because OHSU has done some really excellent work in and around the safety area. So I'll start off with a little background in history. In the 1990s, we saw a lot of studies that were published highlighting the number of medical errors that could occur during the provision of care. What's really interesting is as a result of that work, we had a lot of health information systems that were identified as possible solutions for addressing these types of medical errors. So systems such as physician order entry systems, decision support systems, pharmacy systems, as well as clinical documentation. So what we had in North America is that policy recommendations came out to actually suggest this idea that we implement health information systems in order to reduce the likelihood of having medical errors occur. And this is a phenomenon that occurred in North America as well as Europe and in other parts of the world. Now what's interesting is in 2004 we started to see research emerge suggesting that technology could lead to medical errors. And this research suggested that technologies could not only reduce medical errors, but they could introduce new types of errors when introduced into clinical settings. So the main finding of this research was that errors have their origins in health information systems. So health informatics research documented the emergence of these types of errors, and I'm going to refer to them as technology-induced errors because that's one of the terms that's used. But you can actually see other terms being used to refer to these types of errors. They're also referred to in some cases as unintended consequences, iatrogenesis, technology-facilitated errors, and also health information system problems. So there's different terms that are used for this particular type of error. In terms of technology-induced errors, we should talk a little bit about the definition. So sort of give you an idea of what we've been doing in terms of our research here at the University of Victoria. We define technology-induced errors as those sources of error that arise from the design and development of a technology, its implementation and customization, as well as the interactions between the operation of the new technology and the new work processes that arise from technologies used. And this includes errors such as actual mistakes, so you have an actual error that takes place involving the technology, and slips, so near misses that occur. So a health professional is working with the technology, identifies an error has occurred, and then actually corrects that error. To give you a little bit of an example of a typical type of issue, a few years ago we did some simulation work. Actually, this work was done in Japan, where we looked at the use of a medication administration system by both nurses and physicians. Now, this is actually just a screenshot. So this was a simulation. There's obviously a dummy patient here. So let's see. So that's the mannequin down there. This is an artificial case. Then where we have a health professional that's actually interacting with the system and also providing care to the artificial patient while using the system itself. And it's an interesting study because what it did is it identified a number of issues, which I'm going to talk a little bit more about. But what we did was essentially an experimental study where we actually recorded what they were doing. We actually took a look at and transcribed what they were actually saying while they're performing the tasks. And then what we did is a semi-structured interview afterwards. It's a form of cued recall where we asked the person what was happening during the actual situation. This also involves looking at video in some cases and actually cueing the person and asking what was going on at that point in time. And it was really interesting, so you could start to see how technology starts to influence practice. So in this particular case, for example, the scanner actually didn't respond in all cases. The cord on the scanner was too short to reach the patient. So these were all potential sources of technology-induced errors. And this was particularly considered a problem in process in terms of health professionals who were using the technology thinking that perhaps it would take too much time to actually engage in the entire sequence of events in order to get a medication when a patient needed urgent help. So some other findings that we had included things such as there were fundamental changes to the workflow for the particular task. It changed from parallel to serial. What's kind of interesting about that in actually doing medications or administering medications, multiple medications, more complex ones, we saw the cognitive load actually increase for this particular group of individuals. So you started to think about the interactions between actually what happens in real clinical practice and what actually happens in terms of how the technology is designed. So it might have been designed more so for someone administering 1 or 2 medications rather than 10 medications, and some of those medications may include things such as oral meds, they may include an injection, and they also may include hanging IV medications. So what it started to do is start to look at the kinds of issues that might actually potentially introduce potential errors into the system. Because when you have the situation occur and a health professional really wants to get an outcome, I want to make sure that my patient gets their medications so they can improve their health, you start to see health professionals trying to, in essence, work around the system. And these workarounds sometimes lead to errors. And the workarounds are a result of poor technology design and oftentimes poor technology implementation. Other examples that we've seen of technology-induced errors in the literature include things such as fragmenting of patient information. A study that I did, I looked at how nurses perform in pure paper versus hybrid environments. It was really quite interesting. The number of data points that the nurses attended to in the paper environment were much higher than the number of data points that they attended to in the hybrid environment. Interestingly enough, when they were asked, so what was happening in the hybrid environment that led you to behave in the way that you did, the nurses identified that it was very confusing to be able to move between the hybrid and the electronic record, and as a result, they cut out from their decision-making, their actual formation of their mental model a lot earlier. So their mental model was robust in the paper environment, but not so much so in the electronic environment because of this confusion and moving back and forth. Other things that have introduced errors, technology-induced errors, include layout and organization of information. Also, there's been some research that has shown that people can become screen-driven as a result of the way that the system presents the information, and that can actually lead to suboptimal clinical practice. In addition to that, there's specific features and functions of user interfaces that actually may be associated more so with technology-induced errors, such as, for example, defaults. You have a default that auto-populates a particular field. The health professional thinks that they've entered the correct information, but in essence what's happened is the default has popped in a different value, and then they submit the order. Okay. Another example. Other things that have happened in terms of technology-induced errors include things such as documenting on the wrong patient record, and that can sometimes happen because of the color of the font on the different records, or you might not realize you actually have more than one patient record open at the same time. One of the issues also that is kind of coming up in the last couple of years is this whole notion of visibility of the information in the record. as you use smaller and smaller devices to view patient information, it becomes more difficult to actually see what is there. In addition to that, you can have records that have poor navigation. They can be inconsistent. A good example of that is the date, month, and year may be inconsistent between different modules within the record, leading someone to make the mistake about when the last medication was given. Terminology differences exist between records and even within records, and you can also see that workarounds are a significant part of trying to actually work with these records, and they of themselves represent an opportunity to have a technology-induced error, because the workaround arises from the technology's poor interface design or poor workflows. So where does technology-induced errors come from? They come from requirements, specification, design, development, programming, customization, implementation, as well as maintenance of the system. What's kind of interesting about that is if you look at technology within the context of healthcare, healthcare work in of itself makes technology or pushes technology to the point where we have to create systems that are extremely robust in order for that technology to respond effectively, efficiently, and to support health professional work. Health professional work is time limited, it's variable, it's uncertain, it's highly complex. There's high degrees of urgency at different points in time. It's also heavily regulated by, in our case, federal and provincial levels of government. So it's very, very complex, and I know in our area and in Canada, oftentimes healthcare is often compared to aviation or banking or even nuclear power, and I would suggest that we are even more complex than even those areas in terms of the types of technologies that need to be developed in order to support work. So it's the uniqueness or the context of healthcare that actually makes technology have to be able to be more responsive, more fluid, more better developed in such a way that it will actually support health professional work. This is a model of technology-induced error that I worked on a couple of years ago. Now, what's interesting about it is you can have errors introduced at different points in time. So, for example, this is the individual. So this is what I call the healthcare professional who's working with the technology. And there's a lot of insertion points in terms of where an error can actually be introduced. So for example, let's say you're working with your health information system and the government changes some fundamental regulation on a particular day. The health information system doesn't necessarily support that particular regulation. Then the health professional uses the system and makes an error. Is it the health professional's fault? You might have errors introduced in other parts. For example, you might have a vendor system that builds their technology based on a model healthcare organization. Oops. What happens if that particular model healthcare organization has errors in it? Errors in processes. The errors become embedded in the technology and the process of programming. You take that particular vendor system and you move it into another organization. Then that organization takes on those errors also. You may also introduce errors from the perspective that that model organization may model a different type of healthcare system. So, for example, there may be one approach to providing care. So let's say Canada and the United States both have different types of healthcare systems. There are similarities and there's some differences. And sometimes those differences emerge actually in the software, and you start having to make modifications to the software to replicate processes or those differences in the healthcare system. There's a vendor organization. You can have issues with how the vendor did requirements gathering, designed the system, programmed it, how they did their software testing. You can also have issues introduced or technology-induced errors introduced at the local healthcare organizational level. So, for example, in addition to the software itself, the local organization may have different devices. They may have different workflows from the model organization, their interface design. They may want to change it. You might have different use of local terminologies versus what is actually in the vendor system. Different policies and procedures versus what was originally supported in that vendor system. And as well as local testing may actually, if it's not done adequately, may actually not catch certain types of technology-induced errors. And then last but not least, you have the individual using the system incorrectly in some cases. But they may be using it correctly, and all these things may lead to an error occurring at this particular point in time. So I have a background in the quality improvement literature, and if you look at the quality improvement literature, it's really quite interesting. 90% of errors are systems related, and 10% are human errors. And this starts to become important when you start looking at that individual who's actually using that particular information system. And you think about all the different insertion points where you could actually have something changed that would lead to an error, some form of error that would occur down here. So I'm an advocate of very much so taking a systems approach when you start to look at technology-induced errors, because something might happen down here, but we need to track back to find out where the root cause or source of those particular errors is. What's interesting about technology-induced errors is we're just beginning to start to document these types of errors. Although there has been some documentation of it, we're still introducing new technologies. We're still interfacing electronic health records with differing types of medical devices, and we're introducing new types of consumer technologies that have healthcare applications. So we still don't know what all the different types of errors are. So every time the software is introduced, hardware is introduced, and systems are integrated, or you make any modifications, there's always an opportunity for some type of technology-induced error to occur. So I have the hypothesis that this is an area of research that will be ongoing for many, many years. The main reason is as technology changes, new errors will be introduced, and we need to be able to identify when and where they're occurring and prevent them from occurring in the real-world setting. So part of that is understanding how that technology works and how it works in a complex healthcare system, as well as the situational context and patient context where those errors can emerge. So why is it important? We need to develop prevention strategies and identify solutions. We need to identify models as well as the underlying reasons for why these particular technologies-induced errors occur, with this idea that we need to have best practices in how we actually implement systems, how we design, develop, how we gather requirements for developing these types of systems. The beginning of that is understanding how these errors occur, and there's a number of different types of models that have actually come out. And it's interesting, there's models that have their origins in the human factors, the organizational behavior and socio-technical literatures, as well as software engineering. And there is overlap between the models when you start to look at them. What's interesting is the human factors models actually look at the human-computer interaction literature as well as the cognitive science literature. And there's quite a few that have been developed for this area. So, for example, Zhang developed a cognitive taxonomy of classifying errors. Blum-Rosen also developed an input-output model for looking at unintended consequences where errors are concerned. In addition to that, we've had other organizational behavior theories and social-technical theories that have informed these models. Social technical theory has been extremely important, and in fact, it's actually mentioned in the Institute of Medicine report in and around health information system safety. And also with Rogers innovation diffusion theory, also looking at how technology is disseminated and what aspects or attributes of the technology may influence its dissemination. And this actually has importance because, a technology that's not disseminating well may have errors associated with it, and tacitly health professionals are trying to figure out a way of saying, well, maybe this isn't working for me or if working for the clinical setting. So you have to consider these types of things when looking at technology and looking at how you actually design, develop, and implement and then maintain it. Last but not least, there's software engineering models. Now, these are important from the perspective that these are the technology designers' models in terms of looking at the technology, how they would go about designing it and testing it and making sure that it is available for use in a clinical setting. Part of these models are important from the perspective that they can also be used to test for safety. So what do we need is we need a number of different types of methods to actually diagnose technology-induced errors, and they need to be unique to the healthcare setting. What's kind of interesting is if you look back to 2004 and the work that's been going on in the last couple of years, both qualitative and quantitative approaches have been significant from the perspective that they have shed different lenses on this particular type of problem. I always like to think of quantitative approaches as counting the number of errors that occur out there, and qualitative approaches actually describing them. Ideally, I think we need to have mixed method approaches where we're actually identifying and describing errors as well as counting how often they occur. Now, in terms of the continuum for looking at technology-induced errors or diagnosing technology-induced errors, you can look at them in terms of different methods and approaches that can be used before a system's implemented, during its implementation, as well as after an error has occurred. So we're going to talk a little bit about that. It's kind of interesting. What we did in Canada is we actually identified a particular methodology that could be used to look at before systems are implemented. So I'm going to talk a little bit about evidence-based safety heuristics, clinical simulations, as well as computer-based simulations as part of our work. early on what we did is we looked at some of the research in and around when errors actually occur and the types of errors that occur. And you can actually bubble that down into 4 different areas. You can have technology-induced errors arise from content issues, workflow issues, and functional issues, as well as the lack or absence of different types of safeguards. So, for example, the decision support system that will warn someone that there is a particular issue. And we looked at that literature and actually developed this based on a review of different types of articles as well as discussions amongst several different experts. And here is an example of some of the heuristics that we use. Now, what we've done since then is we've actually applied this to differing types of health information systems and successfully been able to identify potential issues with a system before it's been implemented. And this type of work can be done by an analyst, so an analyst that's looking at a system or multiple different systems that the hospital may decide to actually purchase. And you can identify potential safety problems before the purchase actually takes place. So the other thing that we've used is clinical simulations. What we recognized in using heuristic evaluation is that it has limitations. It doesn't actually capture the dynamic elements of a particular health information system and how it functions within the context of a real-world clinical environment. So what we did is we worked on this idea that you have a clinical simulation, and it would be a methodology for identifying potential technology-induced errors before an implementation occurs. So what does that involve? Observing health professionals, interacting with systems, using representative devices in typical workplaces, carrying out representative tasks. And representative tasks can be varied from the routine to the complex, the typical to the atypical, and the non-urgent to the urgent. Now, this is really important to consider from the perspective that most health information systems are developed for more routine tasks, typical activities, and non-urgent activities. So this idea that you have this range in these different areas is very important from the perspective that you want to be able to throw a wrench at this system and say, let's see how far we can push it and how well it supports work in unusual situations. Because we know as healthcare professionals, we always encounter the unusual situation, and we need to have systems that can support that. This work actually was extended. There is a group actually in Denmark who have a simulation lab, where what they've done is they've taken the clinical simulations and added the technology component to it and used this particular approach to actually identify systems that would be candidate systems for implementing in their particular regional health authority. In fact, they're using this approach to identify systems that would be suitable for purchase as a part of a procurement process. So important things to remember with clinical simulations: you need to make sure the environment is similar to what you would typically be working with, the tasks are similar, the users of the system would be similar, as well as scenarios. So you have this notion of ecological validity, so you can have representative findings. So if you're actually going about procuring or purchasing a system, that you actually put that system through the same pressures that it would normally experience in your particular clinical setting. Again, with this idea that you're testing it out before you actually implement and have downstream effects. So again, clinical simulations is a great way of actually doing this type of work. The video recordings are extremely informative. The computer screen recordings give you an idea of how the software performs in terms of interface design and workflow. And the other piece, too, and most importantly, is you get health professional feedback on different types of situations. We've had successes in terms of this particular methodology, in terms of convincing people to make modifications to health information systems, changes to the types of devices that are used in conjunction with electronic health records, changing policies in organizations, as well as developing different types of training approaches. So an extension of this particular methodology also includes computer-based simulations. So in this particular case, we have clinical simulations that take place. And what we do is we use that as inputs into computer-based simulations, so you can actually make projections about the effects of a particular technology-induced error over time. The importance of this is that what you can do is you can actually show decision makers what the implications are of making changes to the software or to the workflow that's embedded in the software through changes to the actual interface. And then they can see what the implications are. Imagine an error that is an important one that commonly occurs with your particular system, projected out over a period of weeks, months, and years. And this is all in an artificial environment, which is, in essence, a nice way of finding out what the potential problems would be And do you really want to have those particular problems? It becomes a very convincing argument when you work with chief information officers and chief medical information officers about deciding about what aspects of the user interface design might actually be changed. And it's a nice way of actually managing risk, because what you can do is you can start looking at errors that were created in a clinical simulation environment, and you look at which particular errors you can develop policies and procedures for, which ones you can develop training for, and which ones you actually can actually spend the cost and the money to change that particular user interface. Of course, there's ethnography, and I'm going to mention this because I think this is a very important methodology, and I think there's been a lot of excellent work that's been done here as far as clinical simulations and ethnography at OHSU. Now, ethnography is really, really important from the perspective that you can catch a lot of errors using this particular methodology. And what's beautiful about this particular methodology is it shows that healthcare professionals can actually identify instances where health information systems errors are occurring, and that they see these things occurring in real-world settings and are able to report on these particular types of errors. Really important from the perspective that it gives an excellent argument for why we need to construct monitoring systems and reporting systems for health professionals, so we can start look at collecting this type of data so we can provide this type of information to health information systems vendors. And of course, the other thing too is in this particular, at Oregon Health Sciences University, you've also pioneered rapid assessment approaches, which allow you to actually collect this kind of data in the first little while after an implementation. Extremely important from the perspective because people are starting to learn how to use the health information system, and you can particularly identify those types of issues that can be addressed from a training perspective and let people know how to effectively use the system so you can prevent errors from occurring. Last but not least, there's also methodologies that have been developed after a particular error has occurred, and these are important also. They allow us to actually look back at that particular model and say, where were the sources of the error? Where can we, in essence, close some holes in order to prevent that individual, that clinician, from making an error? And a good example of that is some of the work that was done by Jan Horsky, where he looked at the root causes and potential causes of errors involving failures of interaction. And it's kind of interesting because when you look at the methodology that Horsky uses, what he does is he scopes out the need for actually having a broader view in terms of the types of data that you would have to look at and the types of experts that would need to be involved. You no longer have a team of individuals who are perhaps clinicians looking at how an error occurred. You need to start including health informatics experts. You need to start including people who understand human factors and software and hardware and how things are put together in order to be able to address these types of errors. So I'm also going to talk a little bit about usability. Usability from the perspective that it can actually be a methodology for identifying potential errors both before, during, and after implementation. Now, what is usability? It's essentially a measure of ease of use of a system and learning in terms of learning, effectiveness, efficiency, enjoyability, and last but not least, safety. It's kind of interesting that this has sort of been latched on in the last couple of years from the perspective that it occurred in other literatures, but less so in healthcare. So what is usability? It's an individual who is using a system. We ask them to think aloud while they're using a system and in response to a particular type of case. Usability involves different methods. So we have inspection methods, which I've talked a little bit about. We have usability testing methods that you can use where you can actually look at the occurrence of particular usability issues in relation to differing types of technology-induced errors that are present out there. So there's direct correlations and connections between specific types of usability problems and whether or not an individual actually makes a mistake. And then what you do is you can look at usability in the context of clinical simulations where you start to understand what specific aspects of the user interface design and the workflows actually lead to errors occurring from a technology perspective. So if you look at models, you can start thinking a little bit more broadly here where you start to look at how do you make a system safer. You can start thinking of it in terms of phases. So when would you do this? You would perhaps start looking at the safety of a system while you're actually developing or designing it with prototypes. You could do heuristic evaluation on that and correct defects. You could do testing in and around it. You could do clinical simulations. You could, again, correct defects in and along the way. You might even go as far as to do naturalistic testing, so in situ testing, ethnographic observation, and you might be able to actually identify errors that occur down here. Now, this is this idea that what you're doing between here and here is you're pruning off the number of errors that are experienced. The earlier you take care of this problem, the less costly it is. So down here, you could actually take care of it while you still have a prototype. So you're not spending the money on developing a full-blown system. The vendors can be involved in this type of process. And as you get closer and closer towards implementing that particular system, what you're doing is you're adding on these different layers of testing. So by the time that you're done, you have a fairly safe system. Okay? It's gone through multiple different layers. And there's no difference between this particular type of approach in terms of looking at layers and doing testing at different points in time and what you have, for example, in the aviation industry. It's seldom that we have Boeing, for example, probably wouldn't develop a prototype and expect passengers to fly in it the next day. Instead, what they're doing is they're actually going through this process, this layering, to identify potential issues so that they can produce the best aircraft possible. So the day that it's launched, it actually is very effective and very safe, as we can see. So I'm getting closer to the end of my presentation. I think technology-induced errors are very, very important. I think we're just at the tip of the iceberg of these types of errors. Interestingly enough, I think there's a lot more down here, and probably this will either grow or shrink depending on how much we identify in terms of best practices. And best practices are key here because we can probably shrink this if we have more individuals doing testing and identifying what kinds of issues could potentially happen and correcting for those things before a system is actually implemented and used. I think today what we're in is a situation where you have some health information systems that are safe and some that are unsafe, and it's a continuum. So you might have different system features or functions that are in here that are safe and unsafe. And this is the beautiful part of it, is we need to find out what's good in here so we can move towards safer systems, okay? And this is a process, and it takes time, but we need to start doing this more effectively, and we need to have more research in this particular area. And one of the reasons why I'm here is because research in this area has occurred here and is moving this particular continuum forward. I'm also very pleased in saying that some of the research that's happened here, as well as in Canada and other parts of the world, led to the Institute of Medicine really looking at technology-induced errors and going from a point where they said, we have to go down the route of implementing health information systems to now highlighting this idea that we need to build safer systems and that this is a concern. And it happened in a very short period of time, 2004 to 2011. I think that's a very short time period considering the amount of time it takes to disseminate knowledge. In the next couple of years, I think what's going to be interesting is we're going to have to look at things such as the infrastructures that are used to actually look at health information system safety. We need to identify what reporting and monitoring systems are needed out there, given the fact that these errors have not been not all the errors have been described. Some have, and that more errors and different types of errors will emerge in the next couple of years as we introduce new software and new technology, new hardware devices, and we interface them. We also need to have these types of methods where we start to test to see what types of safety issues may emerge with that particular type of system. And in addition to that, we need to start thinking about how we provide feedback into how we can improve these types of systems through these types of tests before these systems are implemented, before clinicians use them. An idealized world would be is we would have technology-induced errors occur at a minimum, and that we would have clinicians feel that they're comfortable with their information systems and that they're safe to use, and not have to worry about, did that default pop up at the last minute? They should be thinking about whether or not, whether they should be comfortable with knowing that I've ordered the right medications and the default has been, and it was correct. And all of this actually factors in terms of best practices. So little baby steps to create, in essence, best practices in around how to deal with technology-induced errors across this entire continuum. And so I'm actually really happy to be here from the perspective that there's been people here who have worked on safer guides, which to me is very important because it's bringing this idea forward that we need to start doing safe best practices, and there are resources that need to be out there for all of us in the industry to use, from the vendor through to the educator, through to the implementer in a hospital, through to the consumer who's out there, who is sitting there looking at their system going, I don't know if that worked correctly. Is it giving me the right information? So these are the kinds of things that we need to consider from that perspective. This is my contact information if anybody wants to contact me afterwards. And that's the end of my presentation. Oh.
So question, and let me ask you to repeat them because the people listening won't be able to hear it. But the question I have is, how generalizable are the results from your analysis? I'm thinking in terms of if errors with health IT are related to sort of systems and their local implementation and people and the things they do locally, if there's so much variation. I mean, we hear this about health IT, that it's not a one-size-fits-all. But if we're going to make a headway against errors with the systems that we want people to use, how are we going to do that? I don't imagine every small community hospital can be doing usability studies and bring in usability engineers and so forth. We just like to have actually get a clinical informatician in there, but how do you see this sort of scaling out to address the very real safety problem?
Well, I think what's interesting in looking at the research and doing some of the research myself is there's certain types of errors that are consistently occurring, and they're not necessarily specific to a vendor. So a good example of that is default auto-populates a field, and the clinician misses that. And that's not the clinician's fault. That's something to do with the actual system itself. So you could actually, in essence, turn off the default for that particular field. Now, knowing these types of things, you could actually develop guides for vendors where they actually start to see that there's certain things you do in a health care environment and other things that you may not do. Unfortunately, I think we are just beginning to sort of scratch the surface of this. So we need to start having guides where we're detailing out this information, and these guides over time will need to be updated depending on what type of research is out there. In terms of usability testing, my colleague Vanja Kushner has actually developed a low-cost approach, and it's kind of interesting. You can actually do your usability testing in your local regional health authority, and in fact, it's quite commonplace for people who are either taking graduate studies or undergraduate studies in our program to actually conduct usability tests with technologies. What's kind of interesting about that is they've been effective in actually making changes to the technologies as well as providing feedback to the vendors. So I've done my usability test, identified that there's certain usability issues associated with technology-induced errors. I provide that to the vendor as information in terms of their releases, and I also have that information to make changes to the product locally. So, and again, it addresses this whole notion that perhaps, you might have some differences between organizations. But increasingly, I mean, if you look at technology itself, there's certain aspects, certain technology-induced errors that keep recurring, so we can develop some standards in around what should and shouldn't be used. We can also do localized testing to address what happens when you implement something and identify what potential issues there are and make modifications or customizations at that point, as well as provide feedback to the vendor. Because I don't think these cases are unique. I think the vendors need to hear the same story over and over again to make modifications over time. I hope I answered your question. Yes.
Thank you for coming and sharing this research. It's excellent. One of the questions I have emanates from your comment about how some of the technology was designed arguably for some more simplistic care type models. I was wondering whether in your research you looked at or saw the issue that many of these technologies unfortunately were designed for reimbursement purposes. In other words, to capture charges in a day where healthcare cared more about billing and
So the question was, did I see anything in and around technology-induced errors and the fact that systems were developed initially for reimbursement purposes?
And capturing charges as opposed to, so in other words, if somebody is developing a system with the idea of capturing those charges, for whatever, for the billing system, unfortunately that's what we have in the United States, then we're going to spend less time and effort, I would think, on the types of issues that the rest of us would be concerned about, because the finance people are often making those decisions to purchases, and that was what it was for. Do you see anything in your research?
No, I mean, in my research, we haven't actually looked at it from that approach. And from what I've looked at in terms of articles, there isn't that specific focus on that particular issue. I think what you're seeing more so is how do these technology-induced errors, how do they emerge when a person's dealing with an urgent clinical event. And I guess, this is a value judgment about health information systems, right? Should they be used to support patient care or just to collect information from a billing perspective? And can we find something that sort of rests in between where it services both worlds, right? You can still collect your information, but at the same time, you have something that will be very safe. Because ultimately, if you have an error occur, a technology-induced error, and it leads to harm to a patient, there's costs associated with treating that patient after the fact, right? And the costs are high. So, I mean, it makes sense to make a safe system, right?
In the past, if an untoward event happened to the patient, a healthcare system got paid more by treating the patient after the untoward event. Thankfully, that's starting to change, but the whole system was, well, thank you.
I mean, in theory, you could wipe out any savings you had using the information system if you had enough errors occur, right? I'm going to go to the fellow with the blue shirt, because, yes.
Thank you. What can field researchers focusing on workflow in different care settings, how can they inform simulation studies like yours? What do you look to the field studies for, both qualitative and quantitative, to help you design a ecologically valid simulation?
Well, so the question is how can field researchers and field research contribute to the development of ecologically valid simulations? I think it's interesting that you mention that, because you can actually use that research as a way of informing how those particular simulations are developed. In fact, what you can do is you can identify cases where you feel that errors are occurring. And, for example, someone's correcting. You have a health professional who's working away, and there's a mistake, I have to fix it. But you could actually look at that and say, okay, how can we replicate that in a clinical setting, in a clinical simulation context? Then you could redesign that particular user interface and see if it went away. And if it does go away, then you can provide a rational argument as to why you might need to change that user interface. So it makes total sense, and it's a way of improving the actual implementation, as well as you can provide feedback to the vendor, right? Because the system is there. Yes. Any other questions? I'm going to go down here and then up. So, yes.
Can you talk a little bit about what kind of reporting structures you have for errors in Canada, whether they're mandatory, voluntary, and anonymous or not, and how you see reporting on technological errors as fitting into that? Because if we're looking at errors as a system problem, then even technological errors that were for software design are part of the systems. It's not really blaming healthcare providers anyway. Healthcare providers should be looking at what the system is doing. So how do you think those are part of the same reporting system, and what is your explanation for reporting?
The question isn't around reporting and where the reporting takes place and what kinds of experiences we've had in Canada in around reporting. Now, it's interesting that you mentioned that, because there's been a lot of changes in the last, I would say, 2 to 3 years in Canada in and around technology-induced errors. First of all, we had a sensitization in the vendor environment as well as the clinical environment. These particular types of errors occur. So now you have these errors, and where do you actually report? And there are no unique reporting systems for technology-induced errors. Okay, so there was a period where people were reporting them to their incident reporting systems at the local regional health authority. There were people who were also reporting it at a national level when it involved medications. What happened, and also to Health Canada, which is similar to your FDA, So Health Canada, what was interesting is they looked at electronic health records and medical records, and they identified that in certain cases they are like medical devices. So they are labeled as medical devices, and with that you have reporting that takes place. Now, with reporting, it's kind of an interesting area. One of the things that I have noted is we all know what unintended consequences. We know what technology-induced error is. In fact, it's really interesting because we know that language. Our language needs to be transferred to the health professionals. I can tell you that I've presented this lecture and other lectures to health professionals where they don't know what it is, but then when you give them a definition and some examples, it's like, I've had these things happen. I didn't realize I was supposed to be reporting them. I thought I was just supposed to call it into the help desk. And yet, so once we sensitize individuals, I actually fully expect there's going to be a spike in terms of the types of reports that are out there, just because people are now aware of what that means and how it affects their work. The good thing about that is that we're going to bring, from that iceberg, we're going to bring a little bit more up. We're going to see more, and then we're going to be able to address more of these types of errors from a health informatics community perspective through the software development life cycle and through to maintenance of these systems over the long term. And the other piece of it is we're going to influence next generation products with these best practices that some of them which you've identified here and published about. So we'll have better systems over time. Yes?
So my question takes up a little bit from what Bill said. You showed an example of software which is relatively unique in the software industry in that an unfinished product is essentially sold to the customer, and the customer then customizes the product to their specifications. Knowing that the errors that occur are complex, I would be interested in your take on how we can differentiate errors that occur because of system design as opposed to errors that occur because of the customization that occurs to these systems, and whether there are different rules that apply to these two separate types of errors, or whether there's a universal process we can use to reduce these errors despite the customization.
So if I can recap this, so you're looking at, you want to know how we can go about addressing errors that arise from system design and errors that arise from an implementation perspective, and how we can actually influence this process. Well, I think this idea of having a model where you're actually doing testing along the way is really important, okay? Certainly we have to ask the vendors to do the testing, okay, with prototypes. And we need to identify any potential issues within those prototypes. And as they build the system and it becomes something that can be sold in the marketplace, then what happens is we have people who purchase systems. Okay? In Denmark, one of the things they're doing is they're actually doing this type of testing before they actually purchase a system. They're identifying the best system for their regional health authority, the best features and functions that it has. Now, if you make customizations to the system, another educational point is that health information technology professionals need to understand that when you do that, you can introduce new types of errors. So they need to be cognizant of what the implications of that is. So they need to also do some testing locally. And like I said, we've had successes with people who have graduated from our program who actually do local testing. So you can do local testing in your OR during off hours. You can do local testing in a room that isn't being used for patient care, as in the Japanese example. So you can start to see what the implications of your changes to, or your customizations of that system are at that level. And so again, this is all about creating a safer system over time, and it's all about organizational learning too at different levels. So vendor and also from an organization, the healthcare organizational perspective. It comes down ultimately to organizational behavior flowing through this and making people think that we have to actually look at this from a systems perspective. I hope I answered your question. Yes. Yes?
If I can add to that, do you think the stage 2 meaningful use requirement for user-centered design, as low as that bar seems to be, is a step in the right direction? Should the government be mandating elements of usability at the vendor end before it goes to the client-side customization?
Well, that's a good question. I don't know. It would be great to be able to design a study to see if it had an effect, right? And if it does have a positive effect, right, then I think that's great, and that needs to be published, because maybe what we need to do is have more of a role of governments in terms of regulating this. Okay, I can tell you in Canada there are provinces that have identified specific vendors that were in essence they recommended for use, and part of that was doing usability testing. Okay, now what effect it had in terms of reducing error rates, I'm not sure. That's the kind of study that you can do and find out, right? So it's important. Yes?
Isn't it also incumbent upon the end user to do what the Danes are doing? So, I mean, when I was in Denmark last year, meeting with some folks from the plastic surgery department, they wanted a fix to what the EHR was going to do, and they were planning on making sure that they tested it internally. And here it seems like we have the culture that they're paying the vendor, so the vendor will make it work. Is that what your research shows?
No, I wouldn't say that. I can't say from a researcher's perspective, but as a person who had worked in clinical informatics, we do testing at the organizational level, even for customizations. So this is sort of shifting the focus on the testing to actually start looking at it in terms of potential opportunities to introduce errors. So, and it's not a bad thing. I mean, it's more testing we do, it's like pruning a tree off. You're pruning off the errors, right? So you have fewer errors over time, and then that clinician doesn't get in a situation where something bad happens. Yes, the person in the orange shirt, I apologize.
So, the tree pruning metaphor is actually apt, because to my question, which is, that do you think that we can get to a safe system by these incremental tree pruning improvements, or do you think that there are some fundamental safety issues that really have to do with the whole paradigm by which these systems are designed, and really we need to think of a different way to design electronic record systems that don't have, a million different panels and dialog boxes and dense tables and, that whole sort of, for lack of a better way to say it, just transferring the paper chart to the screen. Do you have a feeling on the balance of that, and or if, safety is sort of, we'll reach some sort of, plateau with which there are certain kinds of just errors that are inherent with that kind of a design?
So I guess so. The question is do we take this incremental approach in terms of pruning off errors, or do we actually create some new type of design that's more safer? That's a very, very good question. I think we're kind of, in some ways, having to do some of that incremental work right now because we have so many health information systems implemented. So that has to be done because people aren't just going to haul those things out overnight. That said, I think there's value to looking at differing types of designs that would be safer. So some of the work that's being done here is really important from the perspective that you're looking at something that would be safer. So it might be disruptive in essence to the existing market, and perhaps because it's safer, more people will buy it. Over time, I think we will have something that's safer. It's going to take a long time. You look at some of the literature in the aviation industry. I mean, aircraft have been around since the early 1900s, right? It's a safe industry. It wasn't for a while there, okay? A long time it wasn't safe. But what they did is they took the information and they brought it back in as a feedback mechanism, and you use that as guides and ways of actually enhancing future aircraft. So today we have something that's very, very safe that's flying out there, and I mean I think it's wonderful because you've got Boeing here. But the other part of it too is that if we don't start investing now and don't recognize this as an ongoing process, we won't get to that level where it's the safest industry out there. And I think we can get to that level. Yes.
You're spot on. A plane crashed in San Francisco a couple years ago. 2 people were injured, and there were investigations up the wazoo. Hundreds of thousands of people are killed every year by hospitals and physicians, and there's no common group that goes swarms down and figures out how to fix it. So we're 100,000, 200,000 people versus 2 away from that. I mean that's a societal issue. I think. unacceptable if we go on a plane and it crashes. We don't view it as unacceptable if our relative is one of 100,000 people killed.
No, and it is partially a culture shift also. I mean, you have pilots that are aware of potential issues with aircraft. They're given information in real time. They train on a particular type of aircraft. They know how it feels, how it works, in situations that are routine and non-routine. Okay, so over time, the people. Actually, the pilots contributed to the advancement of that knowledge. There was research that went into it, engineers, everyone along that path, okay? And they're certainly socialized to say, hey, there's a problem, okay? So what we need to do, I think, as a healthcare industry is say, hey, there's a problem, and then have that addressed and disseminate that knowledge, not keep it behind some back door and say, we fixed our problem, we're not going to tell anybody else about it. We need to say, we fixed this problem, this is the way we did it, and we want people to know how that's done so that you don't have that issue occur for you ever. I'm going to go back and then over. Yes?
I just want to comment on Paul that the culture of precision medicine is changing. We have gone from playing the blame game when it comes to errors to having a more open society to think about errors from a systems-based perspective, to not be punitive. In fact, most of the punitive aspects of errors occur on the legal side. They no longer occur on the within the clinical environment. When you go to M&Ms today, there's a big difference between M&Ms today and M&Ms 20 years ago. The difference is that now everybody bears the EHR. But there is, I do want to point out that there has been a paradigm shift in the way that clinicians think about how we approach errors. So that should be, just like pilots are responsible to some degree for improving safety in healthcare, clinicians are responsible today to some degree in improving healthcare, safety in healthcare. But to take Paul's point to its logical conclusion, we did not know, or we claimed ignorance, much like Roger Goodell. We claimed ignorance, until a few years ago, until the Institute of Medicine report came out. People were honestly shocked by the amount of errors in healthcare, and that includes clinicians. I was honestly shocked as a practicing clinician that so much errors could occur in healthcare. That culture is changing.
Yeah, the comment is that, the culture among clinicians is changing in that we're now looking at things in terms of not blaming individuals, but looking at things from a systems approach. It's really important. What I see, because I teach people about health technology, and they're individuals who deal with that back end, is that we need to recognize there are different partners in this process, and we need to bring these different individuals together so we can actually improve those systems. And it even goes as far as to sensitize governments about this too, because, today you change legislation, the workflow is different from what the legislation says that person's supposed to do, and you're putting that person that's actually using the system in a situation where they might make an error now because the workflow is different. So, again, it's multiple different players looking at it from a systems approach and understanding how that works in order to prevent any errors from occurring. And I saw another hand out there. Yes.
With greater sharing of information between different organizations, there's a potential for erroneous data to propagate. Did you look at all at data governance?
No, I haven't looked at that per se, but there is some research literature that's really kind of interesting, depending on, I've run across an article too, where depending on the degree to which an organization relies on technology to support healthcare processes, you can have a significant rise in the number of error rates. Now, that could be because you're relying on the technology more so now. That said, if you recognize that, and that's a potential issue, that you need to actually go and start developing organizational policies, procedures, and even looking at it from a process perspective to prevent that from occurring, especially if you are having data transmitted from one organization to another one.
Well, the simple use case is that medication reconciliation.
Yes. Really important. And I mean, that's may not be something that a clinician necessarily can fix, right? but they can identify when it occurs. And so that's something that needs to be brought up with the vendors that are involved, as well as the institutions that are involved, because you're going cross-institutional at that point. That's a very good point. Yes.
Okay, well, we should. I assume you can stick around for a few minutes if people have more questions, but thank you very much.
Thanks. It was lovely being here.